Thank you.
Thank you. Next witness, please.
Thank you, Senator and Chair and members. My name is Farah McDade-Ting. I'm with the California State Association of Counties to offer the county perspective on this issue. I do want to go over a tiny bit of history in that this is a growth funding formula that is part of 2011 realignment. So it is simply a funding mechanism for how much the state received in sales tax and VLF, and then how much should be allocated to the counties. The reason this growth formula is in flux still is because we're still trying to get the data, and I do want to commend DHCS because we did talk to them about a month ago about wanting some more up-to-date data, and they did provide that, so they've done a very good job of that. But we're still trying to find our equilibrium in 2011 realignment, and so the base amount that counties get in mental health has not even been set yet. We've been getting the receipts, figuring out the percentage that each county gets, and giving it to them, and then we have this leftover, as you would call it, growth funding. And so we're still trying to figure out what's most important, how do we direct those funds, what factors can we use. I will also reiterate that counties are very well aware of the entitlement programs that come out of this sub-account, and that these growth funds should be spent for. Not only has DHCS helped counties understand that, but I think, again, we've had a lot of movement in the last 3 or 4 years on counties understanding that and putting the money where it needs to be. There are no caps in these programs in any counties currently. I would say that the proposal for this, last year's growth funding, the proposal that's before you for the $60 million clearly is not adequate, but again, it's sort of the leftover, the growth funding that we didn't anticipate. And so we are continue to work with the behavioral health directors and DHCS and Department of Finance, as well as stakeholder input to determine the best way to do that. I just want to say that however this formula is decided to go out, it is not set in stone. Again, we are still trying to identify the factors, as Dr. Baylor mentioned. It sounds very controversial, and from our point of view, it's not. We do want to make sure that counties get the money that they need, but we are under no illusions that this is the money that will solve all the problems. And that was part of the deal of 2011 realignment, that counties take the program, you do what you can with the money you're given, and you add money in where you're required to do so for entitlement programs.
And do you think it's reasonable or not that given the nature of this money, in that it was a deal initially brokered in 2011, given that it's a process that's still in flux, do you think it's reasonable to attach kind of outcome measures, if you will, to the allocation methodology?
I'm not as sure about outcome measures. What we've been looking at with
or policies that would govern its use.
What I would initially, the very top priority would make sure that those entitlement programs are being offered to everybody who needs them. And so what we've talked about in some of the data that DHCS has provided is the claims that counties are submitting for these services. And some counties submit higher claims than others. We think that's a good starting point to see where we need to make sure that those services are still being provided. Ways to incentivize counties, it's hard to understand a little bit that because it's an entitlement program. You need to get the program if you qualify for it. Right. So incentivizing counties, I mean, perhaps we could look at a MHSA model where they talked about outreach and early intervention and education. That's something that can be considered. There are models to consider. But again, we just want to make sure that those programs and services are being provided and being paid for.
Thank you.
Thank you.
Next witness, please.
Good morning. Eva Terraza is Director of Public Policy at EMQ Families First. We operate in 5 geographical regions throughout the state, 32 counties, providing children's behavioral health and foster care services. We reach about 20,000 children and families per year. Because we do have reach within counties, what we constantly experience with county behavioral health directors is that the allocation is capped. And that was true last year, and in conversations this year. I'm glad there's discussions going on with the directors because it's a conversation that constantly reveals that their understanding is that EPSDT is capped. It's critical that the state guarantee timely reimbursement of EPSDT, SMHS expenditures, and incentivize low-performing counties to increase access to an appropriate intensity of EPSDT services. The most recent statewide data available indicates that county mental health plans have only used 88% of their base allocations of EPSDT SMHS, while at the same time many are placing youth on waiting lists rather than increasing the number and intensity of services. Now, you all heard earlier about the growth in the allocation this year, $60 million. Part of the recommendations that we would like to make is to guarantee full and prompt reimbursement of all EPSDT expenditures without regard to initial fiscal year allocations. Set the allocations for all behavioral health sub-accounts funds based on EPSDT expenditures. Advance a portion of total funds to lower performing counties using performance-based measures to initiate spending to increase access to and intensity of services, and advance critical statewide policies, including CCR, crisis services, full implementation of KDA services, and ensure timely access to mental health services for foster youth placed out of their counties of jurisdiction by using the growth funding allocation. We'd be happy to participate in the stakeholder discussions with the department and look forward to further conversations. Thank you.
Thank you. Next.
Hi, good morning. My name is Dr. Lynn Thal from the California Alliance of Child and Family Services, and we represent providers of children's services from across the state. So over the past several years, the statewide penetration rates for especially mental health services to children and youth has fallen further and further below generally accepted levels of need. At the same time, the average intensity of these services has also decreased. So the California Alliance recommends the following. For utilization of growth fundings, establishing a fundamental policy goal of equal access to EPSDT, especially mental health services. California needs to address the wide disparities in access to mental health services for children covered by Medi-Cal. Secondly, growth funding must be used for upfront spending, especially in support of the most underperforming counties. We must change the basis of allocating growth funds from past spending for future desired growth. The allocation of growth funds can be used as critical leverage by the state to advance important state policies that can improve access to appropriate care as required by law. Next, the state must change its practice of allocating growth dollars at the end of the fiscal year. So why should the state withhold excess funds to mental health plans while mental health plans reduce access to federally entitled services and force children to wait for treatment? Finally, several critical statewide policy initiatives can be advanced by using funding allocation at the discretion of Department of Finance. For instance, the success of the continuum of care reform effort is predicated on the availability of EPSDT funding to braid with foster care funds to have seamless continuum of care of supervision, services, and support and treatment. A number of children advocates, including us at the California Alliance, are pursuing better crisis services for youth. A funding allocation could be set to target those services. KDA services seem to have plateaued, even though thousands of eligible youth remained unserved. So marking funding for those services to provide upfront and based on well-defined county-specific plans for expansion could reinvigorate growth of intensive home and community-based treatment. And similarly, using allocated mechanism to ensure the funding follows the child could virtually eliminate the out-of-county problem for foster children and youth. So we ask that we be provided opportunity to join discussions with the Department of Finance and counties on this and related issues. By having all the key stakeholders at the table, it's more likely to come up with a timely and appropriate resolution. Thank you.
Thank you very much. And again, we will accept copies of statements for members and committee staff. Next.
Thank you for this opportunity to share feedback on children's mental health funding. My name is Matt Madaus. I'm the president and CEO of Edgewood Center for Children and Families located in San Francisco. We were founded in 1851 to support the orphans from the gold rush, and today we provide a full continuum of behavioral health services from prevention and early intervention to community-based treatment to residential treatment and crisis stabilization. We're active members of CCC-MHA and the California Alliance of Child and Family Services, of which I'm a board member representing Bay Area agencies. Edgewood touches the lives of over 7,000 children, youth, and families, yet we believe strongly that we can help many more if the EPSDT funding methodology is improved. At any given time, 20% of youth struggle with a mental health condition, yet only a small fraction of these youth are able to access treatment, due in large part to stigma and the public's lack of understanding of children's mental health, but also due in part to the nature of the funding. The distress on the youth from their conditions, as well as the impact on schools and communities, is disturbing, especially when treatment makes such a difference. Despite living in one of the most expensive areas of the country, making far less than their peers in for-profit companies, Edgewood staff are passionate and highly competent. They know how to help the most vulnerable kids. However, in order to do this, we need to eliminate all of the barriers to these youth getting the help they need. Access to services is hindered by the way that EPSTT is administered. There are problems with the current proposed approach to distributing growth in the behavioral health sub-account, and more discussion with stakeholders involved is necessary before voting on this issue. Too many counties consider their funds capped, others are restricted by their county or contracting budget systems, and others cannot wait for the cash until they exceed their allotment, so they keep their contracts under it. Penetration rates and service intensity has actually decreased over the past several years, despite the huge need. We need to adjust the EPSTT payment system so that a portion of funds are set aside, allowing ready access when counties exceed their allocation, while also incentivizing them to help foster youth and those in the KDA class, those most at risk. Our associations have specific recommendations that we ask to be included in this process in order to ensure that counties can meet the entitlement requirements of EPSTT and adequate access is available to all eligible children and youth. EPSTT is an entitlement in part because youth who live in poverty do not have the advocacy and access of youth in wealthy communities. We have a moral responsibility to ensure access for those youth who call California their parent, those youth who live in poverty, those youth who are entitled to access. This is a public health obligation and a social justice cause. Please do what you can to help the kids that Edgewood and you care about so deeply. I also urge you to visit Edgewood to see firsthand the amazing work that we do. Thank you.
Thank you very much. Thank you for your work.
Good morning. My name is Camille Schrader, and I represent 3 Northern California rural counties. And thank you for hearing us today. I concur with all of my colleagues' comments about future discussion and some sort of real, intelligent, and intentional plan around how we manage the EPSTT entitlement with regards to upcoming fully implementing KDA, addressing the crisis stabilization needs that are woefully inadequate, as well as managing the CCR Continuum of Care Reform initiative that is occurring on the social services side. All of those things are going to be up-and-coming issues with regards to EPSTT. Today, the issue is the $60 million and the county's recommendation that the dollars be given based on formula without consideration of the initial incentivizing those counties who used their growth dollars in previous years to provide services and supports to vulnerable children in their communities and in their counties. And there was the absolute commitment that first call on growth was to those counties who invested in their communities, who invested in their children, who invested in mental health services to the vulnerable. It is our belief, absolutely, that those counties, that policy and that message is extremely important, that the counties who supported should absolutely get first call on growth. You could reallocate, you can settle it up later if the claims issue is a problem. Furthermore, there should be some pretty significant conversation about the other growth in the drug Medi-Cal and EPSTT account with regards to the idea that it is capped and those dollars are not being reinvested in children's EPSTT services in many, many counties. So thank you so much today.
Thank you for your testimony.
Oh, one more point. In Northern California counties, it would be very, very good if these dollars could come up front. One of their challenges are cash flow. They don't have the kind of dollars. They're sitting in a state account. It seems to me that at least some portion of this should come up front to counties so that they can then invest that growth account in that year. Some of the problem is they just can't manage it with their budgets and their county auditors. Thank you.
Thank you. Thank you to all who contributed to this. Our recommendation is to hold this item open. So we will be moving forward to our next agenda item on drug Medi-Cal waiver implementation, and invite you to proceed with that.
Great, good morning. So since we last spoke, the department has submitted our standard terms and conditions to CMS back in November of 2014, and we are at the final stages of receiving approval from CMS. We are going to be releasing the draft standard terms and conditions but we'll show stakeholders the changes from November up until April. So we're looking at releasing them this week. We also are going to be releasing an overview of those changes. With this BCP, with this current BCP, what the department is requesting 13 positions to oversee the work of the 5.5 years of the waiver. That is including a new appeals process that providers that do not receive a contract with the county can come to the department to appeal. Counties are also required to submit an implementation plan that the department and CMS will review. There are also some of the significant changes from our November submission to CMS. I just want to run through those very quickly. Those will also be covered under the workload of these 13 positions. Some of those changes is our system is modeled after the ASAM criteria, which is an assessment tool to ensure that the beneficiary is placed in the appropriate level of care. And so CMS has requested the department to do an ASAM designation for our residential providers. We have approximately 800 residential providers in California, and so what the department is going to do is a designation, because the ASAM criteria has 5 levels in the residential service. So we're going to designate all of our residential facilities at one or more of these levels, depending on the services they provide. And the whole purpose of this is because our continuum is focused so heavily on the ASAM criteria, we want to ensure that the beneficiary, if they are assessed to need a certain level, that they actually are placed in a provider that provides those services. So that is something new. We are also, towards the end of our negotiations with CMS, we've been working with our tribal partners, and so there hasn't been language included in the STCs pertaining to the tribal delivery system. So there's going to be some placeholder language, and we're going to be working with our tribal partners on a delivery system for those beneficiaries as well. And that will be rolled out later on in the 5th phase of the implementation. So that's a relatively significant change. We also have been working with CMS. Since we are doing a waiver, we have to have what's known as an external quality review of the mainly access issues, making sure beneficiaries have the protections that they need, those type of requirements. They're known as Federal 438 requirements. Typically, with a waiver, you have to begin monitoring those services, but we requested from CMS more of a phased-in approach, which they have agreed to, since we don't have those services in place to monitor. For example, beneficiaries need to have 24-hour access. If they need services, they need to have that access. We don't have that currently in our system, so there's nothing to evaluate. So that's a change as well. There's also the majority of the changes from November to April, a lot of moving pieces around, adding clarifying language. We've added a lot of language around medication-assisted treatment just to provide more education and assistance. So we're at the final stages, like I mentioned, of approval. We have about 2 remaining issues we're working on with CMS. We're expecting to receive some questions back this week, and then we're hoping to receive approval potentially at the end of May or beginning of June.
Great, thank you. Let's see if LAO or Department of Finance have comments, and then we'll take questions.
Carla Castañeda, Department of Finance. We would continue to support the proposal, the May revision proposal of 13 positions. Given the uncertainty of the timing of the waiver and the county implementation plans to be submitted, the proposed budget bill language would authorize that to begin once the waiver is approved.
Thank you. LAO?
Amber DG, Legislative Analyst Office. We agree with the staff's analysis as explained in the agenda. Based on our initial review of the proposal, we find that the workload described is likely overstated based on the phased-in approach that DHCS has proposed for implementing the waiver.
Thank you. Any questions, comments?
Yes, thank you, Mr. Chairman. The administration has not, in my view, appropriately justified the spending of the $1 million in the technical assistance training. Do any of you have any more information as to, what this is for? Is it for training, or what the rationale is for the technical assistance? Do any of you have any idea what? I mean, it's $1 million.
I can speak to that.
Okay.
So we have, this waiver is a substantial lift, not only for the counties, but also providers. And there's pieces in the waiver. For instance, we're requiring a provider to do at least 2 evidence-based practices, which we currently don't require. So it'd be training on those 5 evidence-based practices, training around the ASAM criteria. We only have about 2 counties in California that use the ASAM criteria currently, and it's been very successful, but it's a substantial shift in how we are approaching these services, because the most important piece of the ASAM criteria is making sure that that beneficiary is assessed properly and receiving that proper level of care. Right now, the beneficiary walks up to any door, says, I need it, and they get it. And we don't want that. We want it to be the lowest level of care needed, and so that they can move properly through the continuum. SUD providers, we've never provided case management services, because as they transition through those modalities, we want to make sure one person is there, making sure they get to that next right door and the door after that. So they're not used to that. The providers themselves aren't used to working through that type of a service. Counties, we are allowing counties to propose rates to us for modalities, because we understand geographical differences, but counties have never set rates for SUD services, so understanding that financial piece of the system. So I could go on and on, but we'd be here till 2 o'clock. But there are extensive changes that we are proposing in the waiver that we just have never done before, and there's a lot of, actually we've been working with UCLA, they're conducting our evaluation, and they're very concerned about this piece in general, because it's one thing to design a great system, but if the providers and counties aren't properly trained in it, then it's going to fail. And so we really want to ensure that we're guiding them through this process.
Thank you for your answers. I appreciate
Great,
the
thank you.
information.
And so that will open up to public comment.
Good morning, Madam Chair and members. Again, Farrah McDade-Ting from the California State Association of Counties. We've been working closely, or DHCS has actually been working closely with us on the drug Medi-Cal waiver. As Marlise mentioned, it is an extremely heavy lift, and counties are concerned about the level of technical assistance, and we want DHCS to be able to do what they need to do with the people they need. While we don't have an official position on the actual numbers that we're talking about today, again, counties want to strongly encourage the legislature to review the proposal and give DHCS the resources they need to help make this waiver a success. Thank you.
Thank you very much. And so it's the committee recommendation that we modify the proposal, and that it's recommended to only approve 6 of the 13 requested positions. In fact, and that's based on our belief that DHCS has used the assumption that all 53 counties that have interest will apply, and fails to account for its own phased-in approach. And it's recommended to approve the proposed budget bill language. So it's a modification. And that's the recommendation with a 3-0 vote. Thank you. Moving on to item 3, drug Medi-Cal residential treatment services.
So this is really piggybacking just on the previous conversation. Part of redesigning the system is to have a continuum of care where you have the most restrictive inpatient services down to something like AA and recovery services. And so we have residential treatment that we have been able to work with CMS on to provide short-term stays, which are 90 days or less, irregardless of the number of beds that the facility has, which is huge. It's never been done before in the nation. I think we've mentioned before how there's a lot of states watching us to see how successful this is, because they want to replicate and implement this as well. So we have already, because we've talked about a phased-in approach, our first phase is the Bay Area, We have already been out there and have talked to the Bay Area folks. They have shown, as we believed, to be a little bit more sophisticated in being able to provide this continuum of care. And as Marlise says, there's a county there that's already adhering to the ASAM criteria. And so based on our conversations, we do believe that there will be residential treatment facilities when we start implementing the waiver. So Marlise's team is currently going out and licensing them first, and then we'll go back out and do the ASAM designation. But we do believe that these counties will be able to start serving these folks as soon as we can get approval from CMS, or shortly after that.
Any questions or comments? Just very quickly, what are you going to do to help get rid of the backlog?
Is that the provider enrollment backlog?
Yes,
I'm going to
yes,
ask
the
Karen
enrollment backlog.
Johnson to come up. Provider enrollment is under Karen Johnson. Thank you.
As well as it was a carryover issue, I think Senator Stone raised at a previous hearing in terms of are these providers certified and how are we going to help them?
Good morning, Karen Johnson, Chief Deputy Director, Policy Program Support. So I'm responsible for ensuring that these individuals get certified. And so we are working on, making sure that we're redirecting staff to help with some of the backlog issues. But we're also, for this particular waiver, new applications that are coming in, we're going to make sure, number one, that these providers are treated, priority within the provider enrollment group. We're also providing training. We did a webinar already. We posted it to our website. And just, I believe, on Friday last week, we did send out kind of a streamlined approach, certifying providers by supplemental application, supplemental form for those individuals that are already certified with our program, that all they have to do is complete the supplemental form and then just indicate the changes in, kind of modalities. So it is a priority. We also are going to have technical assistance, kind of a call center where people can contact and reach out to us if they have questions about how to complete, the form and the application.
Senator Stone? Okay. All right, thank you for that. Thanks for the clarification. LAO, Finance?
Amber DG, Legislative Analyst Office. We agree with the concerns that staff raised in the agenda. And our initial review of this proposal, it's not entirely clear to us that counties will be able to begin implementing these services as of September, given the time to undergo the implementation plan and approval and get services up and running. But we agree with the recommendation to hold this item open as we're continuing to look into this issue.
Excellent. Any public comment? I expected someone from a certain county in Southern California to step up since you've told me that you're ready to roll and not included. Hello? Okay. No public comment on this item. It's a staff recommendation that we're going to hold it open. Moving on to item 4, Medi-Cal caseload update.
Hello, Mary Campbell, Department of Healthcare Services. So the May revision is updated for caseload. It's the largest single adjustment to the Medi-Cal May estimate. The core reason is we do use data that's through January versus July, which is what we use for the November estimate. For 14-15, with the additional data, we're showing an overall growth of 1.3% over governor's budget, so a total average monthly eligibles of 12.1 million in the current year, and then an additional 1.7% increase over governor's budget for budget year to 12.4 million beneficiaries. We also are seeing a lot of shifting among the various categories of eligibility, but without the impact of ACA, we do believe that caseload would be more stable. Other major budget changes of note not discussed in later agenda items include that the actual managed care rate increases came in lower than projected in January, 1.6% increase compared to 3.6%. And then the FMAP change to the CHIP program reduced general fund by $381 million in budget year. The CHIP increase begins in October, so it reflects a partial year adjustment to the FMAP, 3 quarters. It also includes the usual Medi-Cal payment lag, which ends up being about 20%. So as I mentioned, the budget year impact is estimated to be $381 million in general fund reduction. We estimate annually it will be $650 million. Happy to take any questions.
Thank you. Are there any from members? LAO, Finance. Any?
Madam Chair, as the agenda notes, we're not recommending any adjustments to caseload at this time.
Okay, thank you.